Well, hello. This is Dr. Hauk, and I'm going to be talking about evidence-based practice as it applies to diagnosis. So, as usual, we start with the case, and we're using EVP. So, we'll start with a 22-year-old female with a right ankle sprain. Her swelling is extreme. Measured with the figure 8 test, her swelling is 7 centimeters compared to the other side. And we want to know, really, is swelling alone a good predictor of an ankle fracture? So our PICO would be athlete with lateral ankle sprain. Our sign or test would be swelling. The comparison would be something like an X-ray or CT scans, and the outcome would be the accuracy of the swelling and estimating a fracture, and that we would measure with sensitivity specificity values. So is this a real foreground issue? The answer is yes. There's many small fractures that can occur, although not that common. That when they do occur, it would be incorrect for us to pursue functional rehabilitation while somebody has a fracture. And so our ability to detect these fractures is relevant to our clinical practice. And so we can see here's a talar dome fracture, which is a small chip off the trochlea of the talus, posterior chip off the back side of the talus, and then a calcaneal fracture. Some examples of the types of fractures that occur after an ankle sprain. So when we find our paper, we'll have three basic questions. Are the study results valid? Are the results clinically important, and can they be applied to my patient? Those same three questions will be applied to any of the study articles we read during this class. So the hierarchy helps us answer the question about validity. In essence, we want to kind of sort our way through this. It looks something that looks fairly complicated. So I'm going to help. We're going to focus in. We're going to ignore all the systematic reviews. So 1A, 2As, and 3As. We'll ignore those for now and discuss those later. Then we'll focus. So we really want to focus on 1B, 2B, 3B, and 4s. And so the first thing we want to find is how many different study designs do we see in those listings. And so basically we have a cohort study for 1B, a cohort study for 2B, so same kinds of study design. So something other than study design distinguishes a 1 and a 2B. We have something called non-consecutive study for 3B, so that's something about the sample that's specific. And then for 4, we have a case control study. So essentially we only have two types of study design that distinguish the hierarchy. And basically cohort studies are higher level and case control is the lowest. And then we have these characteristics of a cohort study. So if it's a validating cohort study, it's a 1B. If it's an exploratory cohort study, it's a 2B. If it's a non-consecutive study, likely a cohort study. If it's a then it's a 3B. So basically cohort studies have these three qualifiers that rank them as 1B, 2B, or 3B. And then if it's a case control, it's a 4. So let's focus first on the definition of why a case control and a cohort study are important to recognize as a high or low level. So in this example, we see many elements of a diagnostic study that we want to evaluate. And so essentially we just kind of review the basic premise of a diagnostic study. So we're taking a reference standard, which is listed here in this first row across these three different studies. And in this case it's nerve conduction, and we're comparing it to some test of interest that we have. And so in this particular case it's the Phelan's test. So we can see here the criteria for the Phelan's test. So we're comparing whether the Phelan's test in this case predicts carpal tunnel syndrome relative to nerve conduction velocity, and that would be our C. And so what we want to look at to understand why design makes such a big difference, let's focus in for a minute on the samples, because they're really what's determining the design in this case. And so essentially for the Coleman and Hennessy study, we see 180 consecutive patients are being evaluated with referred for electrodiagnostic testing. They also did the Phelan's test on them and compared how well the Phelan test predicted the electrodiagnostic test. And in the Gelman study here to the right, we notice that the sample's quite different. They recruited, phone called, put flyers up, 106 hands with symptoms consistent with carpal tunnel, and then went out and also recruited people with 16 hands with symptoms commonly confused with carpal tunnel, and then also had 50 asymptomatic hands. So the recruitment strategies are quite different, and the samples are quite different. And so we could ask ourselves which one of these samples best replicates how the test will perform for us if we were in the clinic. And we can see here this sample is trying to simulate what's in the clinic, but this sample here with Coleman and Hennessy is actually what we experience in the clinic. So we would have to answer that pretty much Coleman and Hennessy study would better replicate the kinds of confusing diagnoses we would face off with if we were doing the Phelan's test in clinic situations. So this prospective set of consecutive patients that are described in the Coleman and Hennessy study is really giving us a more accurate picture of how the test would perform for us clinically. And so this is a prospective cohort study. And then the Gelman study, which has basically formed groups, like recruited groups of patients, say 166 hands with symptoms, 6 few hands with symptoms that are confused with CT, and then healthy subjects. This is a case control study where we're recruiting the people based on what we know their outcome to be. Okay, and then that is how we create our milieu of people with and without the disease that we're trying to apply the test to see if it distinguishes the same groups. And so that's a classic case control study where there's groups formed, the people are recruited, and many times a case control study will involve asymptomatic hands, which essentially never occurs when we do a prospective consecutive series in people with the disease, because people don't really come to the clinic that don't have symptoms. So what's the consequence, though? So now we kind of have a concept of what to pay attention to distinguish a case control from a cohort study. But now what's the consequence of that on the outcome? And this is really why it's very important for the diagnostic category to be able to identify a case control study. This is our outcome result, which sensitivity and specificity, which are reflecting the accuracy of these tests. We can see that sensitivity is about 50 and the specificity is in the 70s, but if we go to the case control study, the results are higher. And this is typical, that a case control study will typically amplify or overestimate the accuracy of the test because of the way the sample was assembled compared to a consecutive series. So for this one reason, it's critical that if you are going to be a good consumer of diagnostic test literature, to be able to recognize a case control study versus a prospective cohort study for evidence-based practice. And so here we would rank the Coleman and Hennessy study as a 1B. And we'll talk about the difference, and then the Goldman study is a 4 because of their study designs. And then we'll talk about next the difference between a validating and an exploratory study. So essentially, an exploratory study is a prospective cohort, usually, of a study that they're trying to develop the actual rule of the test. So, for example, in the Phelan test that we had just looked at, if we had said, well, we didn't know whether to use a 60-second cutoff or a 45-second cutoff or a minute, 120-second cutoff, which would be the best cutoff to use as criteria for a positive test. That would be one example of an exploratory test where we're looking at different cutoffs or different values. And typically for a cutoff score, you use something called the receiver-operator curve. Now, another way for it to be classified as exploratory is if instead of it's an actual cutoff, a number, you have different definitions of how the test is interpreted. So, for example, if it's lax without pain, if you do a Lachman test, which is for laxity at the ACL, if you pull on the tibia and it moves too much, that could be a positive test, or you could require it to be you moves too much and it hurts. So that's the criteria is being explored, which is better. Okay, that's an exploratory study. A validating study is where the definition or operational definition of what a positive test is has already been defined, and then you're applying that to a new group of patients. So you have a previously defined study, that kind of suggests that some criteria or techniques associated with the test should be used, and then you subsequently use that criteria in a new set of subjects to see if the results hold, basically. And so the reason for this is something called incorporation bias, but instead of basically that's simply when you're using a specific population to develop a test, that there may be some biases associated with that population that lead to that particular cutoff or result. So that's why you need to validate it against a different sample. So this is an example of a study that was used to develop a cutoff for falls risk. And so basically this is the timed up and go test. Basically you stand up from a chair, walk around, walk forward, turn around, sit back down in the chair, and you time how long that takes. And so you see time here on the y-axis. And here's a group. They had a group of non-fallers compared to a group of fallers. And essentially what they're doing here is trying to come up with a cutoff for this test. And we can see in this particular case it's both a case control study and it's exploratory, because they don't really know what value to use to distinguish the fallers from the non-fallers. So if you look here on the 15 seconds, if you put, on the y-axis, if we drew a line here at 15 seconds, basically all of these people would correctly be identified as non-fallers, as fallers, and then these people to the left would be identified as non-fallers. So we could draw a cutoff somewhere around the 15-second mark, which would have very few errors in identifying the fallers from the non-fallers. So that looks pretty good for the examination procedures and the timed up and go test and its usefulness for determining who will fall and who won't. But now let's look at this study, which is applying those same timed up and go test to a different group of people. And here we have prognostic validity of timed up and go test, a modified get up and go, so another test and some other ones in residential care facilities. So a different sample, and essentially what they're using is they're thinking, okay, this timing is going to be good, and so we'll look at different cutoff values. So here we have a cutoff score of 12 seconds, 15 seconds, 20 seconds, 25, 30, 35, and 40, and then we'll report sensitivity, specificity, and likelihood ratios for all those various cutoff scores that are being used to distinguish fallers from non-fallers. And we can see that the same tug score of 15 seconds had good sensitivity, but the specificity was really low. And so the value in this test turns out not to be as good as was predicted by the case control study. And so this is essentially an extension of that first case control study to a prospective cohort study here in this example that's exploratory. They're looking at the possibility of using different cutoffs to distinguish fallers from non-fallers in a residential care facility. And what we notice is that essentially if you kind of look at these sensitivity and specificity values, there's no real single cutoff that achieves accuracy both at sensitivity and specificity. So they either are good, certain cutoffs are good at ruling the condition in, and other cutoffs are good at ruling it out. And so that's an example of an exploratory prospective cohort study. So the rule is, when trying to determine the validity of a study, you have really a couple things to determine first before you want to put time and effort into analyzing the paper. The first is determine the study design. Frequently the low-level studies, like a case control, they're going to overestimate the outcome or the success of the treatment, and therefore if there's a better study design, definitely you should read that rather than the case control study. And if you do decide to read the case control study, it's prudent for you to know it's likely going to amplify the results and overestimate how well they perform clinically. And the second is to determine whether it's exploratory or not. If it's exploratory, it's likely to be less certain in terms of how it's going to perform clinically as well. So the best situation is where you have a prospective cohort that's validating, that has a known value that is likely succeeded in either a case control study or a exploratory prospective cohort study previously, and then it's being validated. Usually those are rules or criteria for categorization, diagnostic categorizations that's successful. And then finally, you want to just make a judgment of whether the reference standard is really good or not. And given those things, if it has those three elements, then that's a good basis on whether or not to decide to invest time in critiquing that particular paper. So once you've done that, then the other issues that kind of influence whether or not how much confidence you have that you'll find the same thing if you were to reproduce that paper clinically, is some issues related to the reference standard, the study population, and the actual diagnostic test itself. So the study sample. So the first issue that we look at once we've kind of determined it's a good paper for us to read is, are the study subjects similar to what I'm going to face off against in my clinic practice? So, and ultimately what ABP is trying to do is get this study to replicate what you experience in practice, so that it kind of can help you get more experience with the test before you apply it or as you're applying it, so you can understand what mistakes are likely to occur if you're to use the test in real life. So in order to do that, we want the test to have the same spectrum of disease severity. So we want them to have more severe disease or less severe disease. So for example, in the case of the ankle sprains, we want them to have type 1, type 2, type 3 severity in ankle fractures. So really severe, multiple ligaments involved, a lot of swelling, and then low levels of involvement. So very little swelling, only one of the ankle ligaments involved. And so that we can know how the test performs across the spectrum of severity. We also want conditions that are confused with the target condition to be included in the study. We don't want them to be excluded. It'd be better if the test could perform across a variety of diagnoses so that we could depend on it to really distinguish the one that we're looking for. So, for example, it's a lateral ankle sprain. We'd want people with medial ankle sprain and people with Achilles tendinopathy and people with acquired flat foot deformity to be included in the grouping, so that we knew that the tests that we were using were successful in distinguishing between those groups of people, because that's what we're faced off with against clinically. So these are the typical, so spectrum is one of those typical issues that you face off with, and essentially the way it's handled clinically is we never really get a sense of all the different spectrums, how well a test will perform in one study. If a test is proven to be successful in one group, it's almost routine for that same test then to be applied into a different group of patients or a different practice setting as a way of handling its success against different spectrums of patients. So for example, the ankle Ottawa rules, which were developed to detect fractures after ankle sprain, has been applied in the emergency room department, has been applied in sports medicine clinics, and things like this. And so that's kind of one of the routine things that happens when we look at diagnostic tests. And the second thing that comes up is, and this is a little bit more abstract, but it's important, is what's the reference standard and how is it applied? So is the reference standard really something that we can connect to in terms of how we're interpreting the tests we're using? So in terms of the swelling example that we've kind of started off with, we know that we're trying to imply fractures, so that means it's a definition of a torn or broken bone, which is pretty straightforward, right? But if we think about something like shoulder impingement, it's what would be our definition of a gold standard of shoulder impingement? Does there have to be disease in the cuff, the rotator cuff? Does there have to be signs of inflammation on MRI? Does it mean pain relief with injection? So those are some of the gold standards that have been used to test shoulder tests. Okay, so you can tell already that the purpose of the test has to kind of match the gold standard in a way that's very concrete in order to help us interpret, what the comparison means between the actual test we're using and the reference standard. So there's usually some it's a critical step for you to think about what the gold standard is and what it means relative to the test we're applying. The other thing that can happen is that the test, the gold standard, isn't universally applied to all the participants. And it says validation bias here, but I think it's also called verification bias. So essentially, the question is, was the reference standard applied regardless of the index test results? So frequently what can happen is a surgical procedure or an imaging procedure is considered better than is usually are expensive and hard to perform. So if somebody has a negative test or a negative result on, say, like they have no swelling, it would be hard for us to justify ordering a CT scan on someone with an ankle sprain that had no swelling. So in the study, we might only send people for verification of their fracture that had a lot of swelling. In this case, the spectrum of the disease would be influenced, and we might say, well, okay, how would we do this? The verification, we might say, okay, well, people with a lot of swelling, we'll send them for a CT scan, and then everybody else will send for an x-ray. In that case, what would happen is we would be using two different gold standards for the two groups of patients. So in the one case, we'd be using the CT scan, which is an excellent quantification of fracture. In the other case, we'd use X-ray, which is good, but cheaper and less good. And so essentially, it might lead to different results if we don't use the same verification method for both the negative people who have a negative test result, or we don't expect the same rates of disease in that group as we do for the people who have more serious disease. And this is really common in diagnostic studies just because of practical issues. And so here I'm trying to help you understand how spectrum really influences our ability to detect the disease. And so if we look across these different pictures of lateral ankle sprain, it's pretty easy for us. This says which is the fractured foot, but let's start off. There's one normal foot in here, and pretty much you can find the normal foot because it's so obvious these other diseases are the severity of the disease is so much worse, right? And so basically, if we ask the same question, what's the fractured foot? Any one of these, the swelling's significant enough, soft tissue damage significant enough, any one of these might have a fracture. So that would be more typical, right? But now if we have the same, we have another set of pictures here. Now we look at the same thing. First, we have to try to find the normal foot or the non-injured foot. Well, you can find it here, okay? But all of these other ones have some kind of disease. Now, from there, find the foot that has a competing diagnosis but not a lateral ankle sprain. So look for a minute, see if you can find it. Look around. Okay, it's not that easy, right? So this one right here is a supinated foot, so it's abnormal, right? So the lesson here is, first of all, these people all don't have as severe of ankle sprains. And then here we have something abnormal. If we throw that in the mix, it starts to make the picture even more confusing. So what we want is the test to perform well under these kinds of conditions, right? And then if we even go one step further here, and now we put in a whole bunch of normal feet, okay, we can kind of see that the contrast changes once again. Okay, and so basically controlling the spectrum of disease influences strongly how well the test may or may not perform. And so it's important for us to repeat the studies across different spectrums of patients so we get an accurate picture of how well the test will actually detect the disease under different patient conditions. Okay, so let's get back to our examples. We have our 22-year-old with a right ankle sprain. She hasn't had a radiograph yet. Her swelling is extreme. So instead of now using swelling, we're going to switch it to a collection of signs and symptoms that are affecting of ruling out a fracture on a radiograph. So we have our PICO there, and we're interested now in what that collection of signs and symptoms is. So here's a study to develop that we found using that PICO study to develop clinical decision rules for the use of radiographs in acute ankle injuries. So the idea is, the foreground question is to detect, only send people for radiographs that actually need them. So not everybody, because it's too expensive to send everyone for a radiograph. We just want to send those people that are likely to have a fracture. And so we can kind of read this through, and essentially the ankle was broadly defined to include the area generally involved in the common twisting injuries. It was subdivided into two zones corresponding to the areas that generally require assessment by standard ankle radiographic areas, the malleolar area, or a standard foot radiographic series, the midfoot. And we defined the zones to include the following anatomic structures, and it goes through those things. So essentially, the study was conducted in the emergency departments, the Ottawa Ankle, Ottawa Civic, and Ottawa General Hospitals, and then all presenting patients with acute blunt injuries of the ankle. Okay, were eligible, and this is really what we want. For the rule to be robust, or the diagnosis test procedure to be robust, we need it to face off against this kind of general population group. And so we look over here for some check marks. Is it a consecutive series of patients? Yes. Is it a representative sample? So it has heterogeneous groups of variety of injuries and ages. Is a large sample. 120,000 patients a year, so yeah, that's going to be big. And the spectrum of the sample is appropriate to the ED. And so that's kind of how we would interpret that paragraph. Now, the next question is, so we know we have a consecutive group of patients, but then the next question is it exploratory or validating? Well, here we have this title. It says Derivation of Ankle Radiographic Series. So the 17 variables were significantly associated with malleolar fractures. We have two continuous variables, so they go through history, age, time from injury. So there was a whole bunch of variables that were actually associated with the fracture. Okay, but what they do here is, look what they do. They go through variables based on physical examination were used for multivariate analysis. They do this kind of sophisticated statistical procedures, and the point of all this statistics is to reduce the number of variables they were using, because they're looking for a rule that's fairly simple and accurate. So if you look here, like some of the things they initially considered were ecchymosis, range of motion, anterior drawer sign, swelling of either medial malleolus or anterior aspect of the ankle, bone tenderness, proximal fibula, all of this. So they end up dropping many of these items, because essentially they weren't as accurate as these items down here that they decide to keep. So the keepers are some combination of variables were found to have acceptable reliability and highly associated with fractures, and were therefore entered for further analysis. Inability to weight bear, both immediately and in the ED, swelling of lateral malleolus within the first 6 hours, bone tenderness of either the inferior tip or posterior edge of the lateral malleolus, and bone tenderness of either inferior tip or posterior edge of the medial malleolus. So then this is a classic example of exploratory. So they're trying to search for certain criteria that kind of indicate a fracture and get rid of other information that's maybe correlated but doesn't perform as well. So this would be a classic example of an exploratory kind of cohort study. It's actually the derivation of a clinical decision rule, because they're using these different criteria for clinical decisions, but it overlaps quite nicely with the idea of exploratory cohort study. So our critical appraisal of that particular paper, we could end it there. It has the positive as an excellent reference standard with the X-ray, the criteria well described, large spectrum of subjects likely to present in the clinic. The negative is exploratory, so it has this incorporation bias to it. Okay, so let's contrast that with this next study, which is implementation of the Ottawa ankle rule in a university sports medicine department. So we see here's the rule. It's being spelled out exactly where to palpate and what x-rays to order. So you order x-rays of the ankle if you have the malleolar zone, and you order x-rays of the foot when you do the midfoot zone. Okay, and so if we look at some of the other check marks here, this particular environment's athletic teams, students, general community, is General Sports Medicine Center treating the whole spectrum of athletic injuries in patients of all ages and abilities. The study included all persons, pediatric and adult, presenting to the Institute from these dates with acute ankle injury, okay, within 10 days. So the only inclusion criteria was had to have an ankle injury, and it had to be within 10 days. So we see here, again, we have a consecutive series of patients, representative sample, so it's a heterogeneous group, a variety of injuries, large sample, but now the spectrum is sports medicine, and the criteria is developed. So this is a good example of a validating cohort study. So the positives are it's a validating study. It's an excellent reference standard, again, because of the x-ray criteria well described. It's a large spectrum of patients, so we would award it a 1B. Okay, so that wraps up section 1 of diagnosis in terms of critical appraisal. Is this study valid?